41 degrees, seizing, skin bone dry. Is this sepsis, malignant hypothermia, or the emergency that contributed to over 1,500 deaths in England last summer alone? By the end of this video, you'll never miss heat stroke again. Heat stroke is defined by a core temperature above 40 degrees Celsius, combined with central nervous system dysfunction, confusion, ataxia, seizures, or coma. Critically, this is not a fever. Fever is a regulated rise in the hypothalamic set point, driven by circulating pyrogens and antipyretics like paracetamol work by resetting that internal thermostat. Heat stroke is the exact opposite, total thermoregulatory failure. The set point hasn't moved, the body has simply lost the mechanical ability to cool itself. That's why antipyretics are entirely useless here and potentially harmful given hepatic and coagulopathic complications. Recognizing this distinction immediately separates heat stroke from every febrile mimic. Get this wrong, and every management decision that follows takes the wrong path. Heat stroke splits into two distinct presentations. Classic heat stroke follows passive exposure to severe environmental heat. Think elderly patients, those with comorbidities, or anyone on medications that impair sweating, such as anticholinergics or diuretics. Their skin is characteristically hot, dry, and flushed because sweating mechanisms have already completely failed. Exertional heat stroke instead follows strenuous physical exertion, athletes, military recruits, or manual laborers working in the heat. Here, the sweat glands are still functional, so patients typically present drenched with profuse diaphoresis, even as their core temperature climbs dangerously. This distinction matters clinically. A dry, flushed patient points toward classic heat stroke and an at-risk demographic. A soaked, sweating patient points toward exertional heat stroke in a fit individual. Same emergency, same target temperature, but a different population. As core temperature climbs past 40 degrees, cellular protein denaturation begins, disrupting enzymatic function across every major organ system. Splanchnic vasoconstriction shunts blood toward the skin, compromising gut barrier integrity and allowing endotoxin translocation into systemic circulation, triggering an inflammatory response that can drive disseminated intravascular coagulation. Meanwhile, myocytes suffer direct thermal injury, releasing myoglobin that precipitates within renal tubules, driving acute kidney injury. The liver takes a direct hit too, with rising transaminases reflecting acute hepatocellular damage. Neurologically, direct cerebral thermal injury produces the confusion, ataxia, and seizures that define this condition. 4 organ systems, one mechanism, heat overwhelming the body's machinery, faster than any compensatory system can respond. Putting this together at the bedside. Neurologically, expect confusion, irritability, ataxia, seizures, or frank coma. Cardiovascularly, tachycardia is near universal, often with hypertension and a widened pulse pressure, as peripheral vasodilation collapses vascular resistance. Renally, watch for acute kidney injury, driven by both hypovolemia and rhabdomyolysis-related myoglobin. Hematologically, coagulopathy can progress to full disseminated intravascular coagulation, with bleeding from cannula, sites a worrying late sign. Gastrointestinally, expect nausea, vomiting, and rising liver enzymes, reflecting tissue injury. No single sign confirms heat stroke. It's this specific combination of hypothermia plus central nervous system dysfunction layered across multiple systems that should trigger immediate recognition and treatment. Management immediately follows ABCDE. Secure the airway, deliver high-flow oxygen, and start intravenous fluid resuscitation, typically normal saline, to support dropping blood pressure. But the single most time-critical intervention remains active cooling, started before or during transit wherever possible, targeting a temperature below 39 degrees. For exertional heat stroke, cold water immersion is the gold standard, rapidly lowering core temperature in young, fit patients. For classic heat stroke, evaporative cooling, tepid water sponging, combined with fanning, alongside ice packs to the neck, groin, and axillae, is preferred given comorbidities that make immersion higher risk. Crucially, stop active cooling once temperature reaches 38.5 degrees to avoid overshooting into iatrogenic hypothermia. Continuous rectal or esophageal temperature monitoring throughout is mandatory, not optional. Investigations should include a full blood count for neutrophilia, urea, and electrolytes, plus liver function tests to assess kidney injury, creatine kinase to screen for rhabdomyolysis, a coagulation screen with fibrinogen for DIC, and a venous blood gas for acid-base status. Before you settle on heat stroke, actively exclude its mimics. Sepsis and meningitis need ruling out clinically. Neuroleptic malignant syndrome presents with lead pipe rigidity and, critically, absent sweating. Serotonin syndrome features clonus and hyperreflexia. Malignant hypothermia is triggered specifically by anesthetic agents. Heat stroke is a genuine medical emergency, killing through multi-organ failure within hours if unrecognized, yet it's entirely survivable with rapid cooling and organ support. Recognize the pattern, cool aggressively, investigate systematically, and always ask what else this could be. In summary, heat stroke isn't a fever. A fever is a controlled temperature rise. Heat stroke is a complete system failure. The body's thermostat is broken. When the system fails, the damage is catastrophic. A wave of heat overwhelms the brain, triggering CNS dysfunction, while simultaneously attacking the kidneys and liver, causing multi-organ failure. The action plan is urgent. First, cool them immediately using cold water immersion or aggressive evaporative methods. Second, target a core temperature below 39 degrees Celsius. But third, stop active cooling at 38.5 degrees to prevent iatrogenic hypothermia. Remember these three non-negotiable rules. First, the diagnosis: CNS dysfunction plus hypothermia. Second, the priority: cool first, transport second. And third, the clinical pearl: always exclude the mimics. This is how we transform a red alert emergency into a stable green zone recovery.